Okay, so this is the third and final part of the video series for the ID competency. We're going to talk about the approach to determining appropriate antimicrobial therapy. So there's a mnemonic that's frequently used in antimicrobial therapy. It's called Be Smart. And so you go through all these different factors to know whether the antibiotic therapy is appropriate, whether you're taking all the risk factors into account. So Be Smart stands for B as in bug. So what is the likely bacteria that you're needing to treat, whether or not it's known, using also where the likely source of the infection is to determine what the likely bugs are, so that you can start the appropriate empiric therapy that will not only cover the bugs that you're looking for, but also penetrate to the site of infection. E stands for evidence-based guidelines and protocols. So utilizing all our evidence-based guidelines to the best of our ability, so those from Infectious Disease Society of America, the CDC. You can also use quicker tools like the Sanford Guide, although my personal favorite is the Johns Hopkins Antibiotic Guide. Purchased it some years ago for $25 for an unlimited subscription, and it compiles all the best evidence-based guidelines together, and it also has specific information on specific bugs and vaccines and things like that too. S would be the spectrum of the patient's regimen. So what types of bugs do the antibiotics that the patient's currently receiving cover? Does it cover all the likely pathogens? Do you need to add on additional therapy? Is it too much coverage? Are you double covering maybe bacteria that don't need to be double covered? Then modifications needed. So doing what we do best, which is adjusting based on renal and hepatic function, taking a look to see if there needs to be dose modifications based on where the drug needs to concentrate. So oftentimes for severe infections, you will use elevated doses of cefepime. So using 2-gram doses of cefepime, maybe Q8 for your ventilator-associated pneumonias, or when you've got a bug that's got kind of an intermediate sensitivity minimum inhibitory concentration. Try to push some of those doses a little bit. ADME and DDIs, so looking at the kinetics, distribution, the metabolism, the excretion, absorption, and then also looking at drug-drug interactions. What are the risks for resistance? What's the likelihood that you're going to come and face a resistant organism to the antibiotics that you're using to treat? Toxicity and efficacy. So what are the chances that your patient's going to have a bad reaction? Looking at some of the agents that may promote renal failure. I know that anecdotally we've seen a lot of issues with Zosyn and renal dysfunction. Also with an old antibiotic that's being used for some resistant agents, colistin, can cause nephrotoxicity. Aminoglycosides, as we know, are notorious for that, especially when you use traditional dosing of aminoglycosides. So when you use the low doses multiple times per day, that actually puts you at a greater risk for nephrotoxicity than using the extended interval aminoglycosides, using one large dose Q24 to 48 hours. And then T, is it time to stop treatment? So what is the recommended duration of therapy? Is the patient getting better? Making sure that we stop those antibiotics when it's appropriate to stop them. So we talk about the bugs. So does the drug cover the suspected pathogens? If it's an infection that's in the lungs, is it going to act against strep pneumo, Haemophilus influenzae, bugs like that? Does it concentrate well at the infection site? So that's one reason why we use respiratory fluoroquinolones like Levaquin and moxifloxacin for lung infections, because fluoroquinolones, especially the respiratory fluoroquinolones, cover the spectrum of bugs that you're worried about and concentrate very well at the site of the lung. Has it had ample time to work? So are we changing antibiotics every 8 hours because we don't see an improvement in the patient? Have we given it long enough to work? And if there's no cultures or negative cultures, what do we do at that point? Do we treat to different clinical signs and symptoms of recovery? Do we look for other causes of the patient's syndrome that's going on? We always have to make sure that we're covering the infectious causes, but we also have to make sure that we're not missing some of the non-infectious causes of what the patient's syndrome may be. So as we stated before, E stands for evidence-based guidelines and protocols. So we've got several different organizations that have useful protocols for us and guidelines, such as the Infectious Disease Society of America, and here is a link to their practice guidelines. We have the American College of Obstetrics and Gynecology. So they have a lot of really useful guidelines, some to prevent the vertical transmission of HIV from mother to infant. In addition, talking about different, treatments for chorioamnionitis. While they may not be the most up-to-date because we don't typically do randomized controlled clinical trials in pregnant patients, they're a good place to start. Ingalls-specific indicator antibiotics. So we've just recently added ceftaroline to that list. Nevenka is going to be talking about that in the near future. But looking to see which antibiotics that we have that are on restriction that we're reserving for specific types of infections or resistant bugs. Other resources include the Center for Disease Control and Prevention. They have excellent vaccine guidelines to let you know exactly for patients, when they should get different types of vaccines, both the timing, and then also if you have specific disease states. So they have some, if you're immune compromised, what kinds of vaccines should you get? If you're asplenic and immune compromised because of that, what types of vaccines you should get. So it's really helpful. My favorite shortcut guide, which is the Johns Hopkins Antimicrobial Guide. And then there's also the Sanford Guide to Antimicrobial Therapy, which has a great table in the middle of it that kind of shows you which bugs are susceptible to which antibiotics. Now, knowing that the different antibiotics cover the different bugs, you have to also consult the institution's antibiogram to know how well our local sensitivity patterns are. And in addition to that, you have to look and see if the antibiotic will actually concentrate well at the site of infection in order to be efficacious. S stands for Spectrum of Patients Regimen. So looking at, do you have an opportunity for de-escalation? So now that you know what the bug is, you've definitively identified what the bug is, do you have the most narrow antibiotic in order to treat that infection? So do you need Zosyn for a UTI that's caused by E. coli? No. You can de-escalate to something that's a little more narrow spectrum. You're going to consult the sensitivity data on that, the culture sensitivity information, and you're going to take a look at what antibiotics are available to you that also correspond with the patient-specific factors such as allergies and drug-drug interactions, and select the one that's got the most narrow spectrum. And then there's also unnecessary duplicate therapy. So these are just no-brainers when you see these. So double anaerobic coverage. The most frequent times I've seen this would be Unicin plus Flagyl in a patient that is not positive for C. diff, or Zosyn plus Flagyl in a patient that's not positive for C. diff, Meropenem plus Flagyl in the same situation. So double anaerobic coverage is a no-no. Typically double antifungal coverage is a big no-no. So we recently saw a case where we were using topical nystatin and systemic fluconazole. Evidence-based guidelines state to use one versus the other, and clinical judgment would state that if the patient's infection is not resolving on one of the therapies, to push the dose of that therapy. So in this case, we had somebody who was getting nystatin swish and swallow along with fluconazole 100 milligrams. Now either one of those should have been sufficient to treat the thrush, but unfortunately this oral thrush was a severe case, and so a reasonable regimen would have been to increase the fluconazole dose significantly to probably 400 milligrams per day. Typically double beta-lactam therapy is inappropriate. So if you've got cefazolin plus ampicillin, that's no good. Double gram-negative coverage for highly susceptible organisms. So sometimes when you suspect that a patient, whether it's because they're immunosuppressed or that they have a history of just resistant bugs, sometimes you might want to double cover gram-negatives if you think the patient's got a severe infection and they've got a high risk for resistant bugs. But typically, for somebody who just has a basic UTI or something like that, you would not provide two different agents that would cover gram-negative bugs. Just doesn't make a lot of sense and is an unnecessary use of antibiotics. M stands for modifications needed. So as we know as pharmacists, we have to modify doses and frequencies on a routine basis. So a lot of times we adjust doses or frequencies based on levels. So we do that for vancomycin, we do that for aminoglycosides as well. for obesity. So there are some instances where there are recommended dosing weights for different antimicrobial agents. A good example of that would be acyclovir. When you look at acyclovir dosing, the literature actually recommends that if a patient is non-obese, that you use ideal body weight for dosing. The literature also recommends that if you have a patient who is obese, that you use an adjusted body weight for acyclovir dosing. This isn't really based on any randomized controlled trials. It's based on just pharmacokinetic data. We also adjust doses based on changing organ function. We have to remember to adjust not only when the organ function is worsening, but to also adjust back up when the organ function is improving. If we give too low of an antibiotic dose, we can actually select for resistance rather than selecting for bactericidal or bacteriostatic activity of the bacteria. And then there can be some pathogen-specific dose adjustments. So based on what pathogens you're targeting or based on the site of infection, fluoroquinolones are a good example of that. We use lower doses for patients who are using it for UTI versus patients who are using it for lung infection need higher doses. And so it's important to know what you're treating when you are going to look at modifying the dose of different antibiotics. And then drug-drug interactions as drugs are added or removed. One significant drug-drug interaction between antibiotics and other agents is the drug-drug interaction between meropenem and valproic acid. So valproic acid is still used to a certain extent for seizure prophylaxis. It's also used as a mood stabilizer for patients with bipolar disorder. When meropenem is added to valproic acid, it results in significant decrease in valproic acid levels, such that you could have a bipolar disorder relapse or you could have a breakthrough seizure because of the reduction in valproic acid levels. So if you do get somebody where they add meropenem onto valproic acid therapy, you want to make sure that you are either getting them on different antibiotic therapy or different seizure prophylaxis. As far as patients who are on it for bipolar disorder or other mood disorders, there's not a lot that you can do for substitution in the acute setting, so it's best to try to switch the antibiotic whenever possible. So now looking at the pharmacokinetics and pharmacodynamics, we look at the different antibiotic classes, whether they're bacteriostatic or bactericidal, and what their PK or PD parameter is. So we know that beta-lactams are bactericidal, and they work best with time above the MIC, which is why we have a lot of continuous infusions that we use, such as with Zosyn, extended infusions of cefepime, soon to come to Ingalls, extended infusions of meropenem. Vancomycin is bactericidal. It's got slow activity. It basically works AUC versus MIC. So the area under the curve being the amount of exposure to the drug versus the minimum inhibitory concentration. Fluoroquinolones, aminoglycosides, metronidazole, and daptomycin all are bactericidal and are also peak versus MIC. So the higher the dose you get, the better the effect is, the better the killing is. Macrolides, tetracyclines, and linezolid are bacteriostatic agents, and they also work on the AUC versus MIC system like vancomycin does, except for the fact that they're bacteriostatic instead of being bactericidal. Resistance risks. So we have to evaluate what the likelihood is that our patient will have a resistant organism. So are they immunosuppressed? Have they had recent antibiotic therapy that they failed or that they did incomplete therapy with? There's a reason why they tell you to take the antibiotics till they're gone when we counsel patients in the outpatient setting. It's because if you only take partial therapy, you're actually selecting for the resistant bugs and you're not killing off the entire infection. In addition, resistance risks can have to do with prior surgical procedures, where you stay. So if you stay at a nursing home, we know that there's a lot more resistant bugs that float around there. When you do get an isolate, maybe you have an isolate where the pathogen has documented resistance. It might have some type of enzyme that confers resistance to specific antibiotics. There can also be the development of resistance while on therapy, so suboptimal dosing. So when we're not targeting the appropriate troughs with vancomycin, we are actually selecting for heterogeneous or resistant strains to vancomycin. So you can actually make somebody's infection worse by not giving them sufficient dosing. So the next time you say, I'm sure that trough is probably good enough for that patient, think again. We definitely want to make sure that we're putting patients' levels in the center of those target troughs. Then there's also selective pressure. So sometimes you're knocking down the levels of the good bacteria, and they are not able to, fight the bad bacteria. So you're causing some selective pressure both with your dosing, if you're doing suboptimal dosing, and also when you don't have anything to outcompete the pathogens. And then unnecessary antibiotic use can result in resistance. So this is also clearing out your normal flora and your normal biome, and just allowing whatever is resistant to the antibiotic that you're using to flourish. We worry a lot about resistance risks because there are no new novel gram-negative agents in the pipeline. So when we look at the antibiotic pipeline, it's a little scary. We've come out with a couple cephalosporins in recent time, but those aren't novel agents. Basically what they've done is they've paired up different types of beta-lactamases with them to try to expand their activity. But we don't have any new antibiotics coming through that have unique mechanisms of action. It's actually kind of scary. Over the last 20 years, we've seen an incredible decrease in the number of novel antibiotics that have been developed. This is such a bad problem that this has actually been labeled a public health crisis by both the Infectious Disease Society of America and the CDC. So when we talk about resistance, there's a few different mechanisms that we think about. So there's enzymatic deactivation of the antibiotic, and that can be done by a few different enzymes. We're not going to go through an exhaustive list here, but just some of the most common ones. So the most common ones are extended spectrum beta-lactamases, Klebsiella pneumoniae carbapenemase, and metallo-beta-lactamases. So what are beta-lactamases? There's multiple types. You've probably heard of them. So extended spectrum beta-lactamases, class C beta-lactamases, also known as AMP-C, and metallo-beta-lactamases. So beta-lactamases are enzymes that open the beta-lactam ring, and that inactivates the antibiotic. The ESBLs vary in activity against different beta-lactam substrates, but cannot attack certain types of cephalosporins and carbapenems. So you can still use cefoxitin, cefotetan if you can still find it, and the carbapenems usually have activity against them as well. They're also generally susceptible to beta-lactamase inhibitors such as clavulanate, sulbactam, and tazobactam, which consequently can be combined with a beta-lactam substrate to test for the presence of this resistance mechanism. ESBLs have been found exclusively in gram-negative organisms, primarily in Klebsiella pneumoniae, Klebsiella oxytosa, and E. coli, but also in Acinetobacter, Citrobacter, Morganella, Proteus, Pseudomonas, Salmonella, Serratia, and several other genuses and species of bacteria. Infections due to ESBL-producing E. coli have become widespread in hospitals around the world, and community-associated infections due to ESBLs have also been recognized as an important clinical problem in both the United States and in Europe. In addition, a substantial portion of the community-onset infection due to ESBL-producing E. coli has been observed among patients with no discernible healthcare-associated risk factors. So this is really scary. Folks are developing bugs that are resistant to all of our common antibiotics without having any real risk factors for resistance. I mean, this is actually pretty frightening stuff. So risk factors for community-acquired ESBLs include diabetes, prior fluoroquinolone use, because basically you've obliterated the normal flora and you've selected for the resistant microbes, recurrent UTIs, prior hospitalizations, and older age. AMP-C beta-lactamases typically are reported as low, mid-level, or high level, and have certain treatment algorithms based on how much AMP-C is actually being produced. So AMP-C beta-lactamases are clinically important cephalosporinases encoded on the chromosomes of many of gram-negatives and a few other organisms, where they mediate resistance to some of the cephalosporins, most penicillins, and the beta-lactamase inhibitor beta-lactam combinations. So if you've got somebody who's been identified as having an AMP-C producing organism, if the patient's improving, you're going to continue the current antibiotic therapy if the pathogen is susceptible. If the patient's getting worse, you want to repeat the culture and sensitivity, and then probably switch antibiotics. So if you're using a cephalosporin, you want to get rid of that. If the patient is not improving or is worsening, if they're receiving a third-generation cephalosporin, you want to change to an alternate susceptible antibiotic based on the culture sensitivity information. And then you also want to repeat the culture and sensitivity. So if you have an organism that makes a lot of AMP-C beta-lactamase, so we call those hyper or high level, causes a lot of problems. So in many bacteria, the AMP-C enzymes are inducible and can be expressed at high levels by mutation. So overexpression confers resistance to broad-spectrum cephalosporins, including ceftazidime and rocephin, and is really a problem, especially in infections due to Enterobacter aerogenes and Enterobacter cloacae. Some of these isolates are initially susceptible to the cephalosporins, may then become resistant during therapy. Transmissible plasmids have acquired genes for AMP-C enzymes, which then appear in bacteria that lack or poorly express an AMP-C gene, such as E. coli, Klebsiella, pneumoniae specifically, and Proteus mirabilis. Resistance due to plasmid-mediated AMP-C enzymes is less common than ESBL production in most parts of the world, but may be both harder to detect and broader in spectrum. AMP-C enzymes encoded by both chromosomal and plasmid genes are also evolving to hydrolyze broad-spectrum cephalosporins more efficiently. Techniques to identify AMP-C beta-lactamase producing isolates are available, but are still evolving and are not yet optimized for the clinical laboratory, which probably now underestimates this resistance mechanism. Carbapenems can usually be used to treat the infections due to AMP-C producing bacteria, but carbapenem resistance can arise in some organisms by mutations that reduce influx or enhance efflux. So basically mutations that prevent the bacteria from absorbing the antibiotic or pump it out as fast as it can be absorbed. So all in all, AMP-C beta-lactamases, when they're hyper or high level, they confer resistance to penicillins, cephalosporins, and beta-lactam beta-lactamase inhibitor combinations such as zosyn and unicin. And it may also confer resistance to carbapenems. So, empiric antimicrobial recommendations when you've got somebody who's got a hyper or high level AMP-C are colistin, carbapenems if you suspect that they still have residual activity, and Tigasil. So the problem with Tigasil, however, is some of the recent data that suggests that patients have increased mortality risk due to use of Tigasil. But also Tigasil just doesn't concentrate well at certain areas for certain infections. So while it may be an option, it's not an option if a patient has bacteremia, an endovascular infection, a UTI, or bacteriuria. It just does not stay in the serum, and it does not concentrate in the urine. If you're going to use carbapenems for empiric therapy, you have to use higher dosing. So meropenem 1 gram doses or 2 grams if the organism is isolated from the CSF. Metallo-beta-lactamases confer resistance to all beta-lactams, including cephalosporins, beta-lactam or beta-lactamase inhibitor combinations, such as zosyn or unicin, carbapenems, and typically monobactams, such as aztreonam, although aztreonam may have a little bit of residual activity. If you have a bug that does contain a metallo-beta-lactamase, empiric antimicrobial recommendations would be aztreonam, but you're definitely going to want to consult susceptibility results, tigacycline, and colistin. But like we said before, tigacycline is not good for bacteremia, UTI, bacteriuria, or endovascular infections. Then we've got the Klebsiella pneumoniae carbapenemase, or otherwise known as KPCs. They confer resistance to all beta-lactams, including cephalosporins, beta-lactam beta-lactamase inhibitor combinations, carbapenems, monobactams such as aztreonam, and so they're pretty scary. Basically, the only antibiotics that you have left that can be used for empiric antimicrobial treatment would be colistin and tigecycline. But again, tigecycline should not be used for bacteremia, endovascular infections, UTIs, or bacteria. In addition to beta-lactamases, there are some other resistance mechanisms that bacteria can have to certain antibiotics. One of them is decreased cell wall permeability, and that happens for some strains of Pseudomonas aeruginosa when treated with aminoglycosides. In addition, when you're using vanco to treat Staph aureus, sometimes you have vancomycin intermediate sensitivity Staph aureus, heterogeneous vancomycin intermediate Staph aureus, and vancomycin resistant Staph aureus strains. So basically the vancomycin can't enter the cell, can't exert its activity. Sometimes there's also altered target sites, so it alters the target that the bacteria or that the antibiotic typically binds to within the bacteria. So that can happen with some MRSA strains and some vancomycin resistant enterococcus. And that also happens with the Acinetobacter baumannii and fluoroquinolones. Efflux mechanisms can also be used, so that's just where you have proteins that are on the cell surface that actually pump out antibiotics. So as the antibiotic gets absorbed, the cell pumps it right out. That happens with Acinetobacter baumannii and fluoroquinolones, and also some gram-negative organisms with fluoroquinolones. Toxicity and efficacy. So basically when you've got a patient who's on antibiotic therapy, you want to screen them for adverse drug reactions, for delayed efficacy, and you want to take a look and see if repeat cultures are negative. So especially with bacteremia, you want to do serial blood cultures to see if the bacteremia gets cleared. You also want to see if continuing symptoms are actually due to the antibiotics. So a lot of beta-lactams can cause drug fever. Now, while drug fever is pretty rare, it does still happen, and it mimics the signs and symptoms of an infection. Some antibiotic-related adverse events include hypersensitivity or allergy reactions, drug side effects, C. diff, and antibiotic-associated diarrhea. C. diff is a big one with broad-spectrum antibiotics. So if we limit inappropriate use of antibiotics, we should decrease our risk for Clostridium difficile infection, because it's actually the C. diff that's allowed to flourish because your normal flora has been knocked way down. Antibiotic-related adverse events account for over 140,000 ED visits per year. 50% of the visits to the EDs are due to penicillins and cephalosporins, interestingly enough, and about 6.1% of all those ED visits require hospitalization. As we said before, T stands for time to stop therapy. So what is a typical duration of therapy for some specific infections that we see? Navenka is currently working on a resource for this to help us, physicians and outpatient physicians, determine when to stop antibiotic therapy. For cellulitis, it's typically 5 to 7 days. The treatment duration should be extended, however, if the infection has not improved in 5 days, and should just be monitored very closely. But 5 to 7 days is typical therapy for the majority of cellulitis infections. Pneumonia, for CAP, the patient should be afebrile times 48 to 72 hours and have no more than one CAP-associated sign of clinical instability before you discontinue the antibiotics. So for pneumonia, you typically say 5 days minimum, or 48 to 72 hours after they're afebrile. Complicated skin and soft tissue infections are typically 7 to 14 days. Intra-abdominal infections are typically to 4 to 7 days or longer if there's an abscess. So if there's an abscess in there, it's walled off. Abscesses are notoriously difficult to treat, which is a lot of times why they go in there and do incision and drainage. If the abscess is not incised and drained, antibiotics have a really hard time penetrating the abscess wall. Sometimes physicians tend to treat intra-abdominal infections longer than the 4 to 7 days. This has actually never been shown to improve outcomes. And they've done head-to-head studies on duration of therapy in intra-abdominal infections. Patients who receive longer courses of therapy do not do better than the patients who receive only 4 to 7 days. Pyelonephritis, 14 days or 7 days if the fluoroquinolone is used. That may be changing. The guidelines are being updated as we speak. And if we take a look at our urinary isolates for Ingalls, we see that there's significant amount of fluoroquinolone resistance, up to 35% of all isolates. Complicated UTI, which means you have some kind of structural anomaly that is causing UTIs to occur. Typical duration of treatment is 7 to 14 days. For complicated UTI, it's typically 10 to 14 days if there's a delayed response. Basically, if you're trying to determine who's a complicated and who's an uncomplicated UTI, any young woman, so any woman less than 40 years old, is typically an uncomplicated UTI. Everyone else, so women over the age of 40 and men, are complicated UTIs. For uncomplicated UTI, you typically treat 3 days, but if the patient is diabetes, you want to treat for 7 to 10 days, just simply because they have more difficult time clearing the bacterial infection. If they're dumping a lot of sugar into their urine, boy, that's a great growth medium for bacteria to continue to flourish. No cultures or negative cultures. So when you get the cultures back and they're negative, or they weren't able to get cultures before antibiotic therapy started, getting cultures before antibiotic therapy started is best practice, but there are some situations where it's not done. The patient is deemed too critical, or it's just due to a mistake in the process. You definitely want to evaluate the patient's status. If the infection can be visualized, is it better or is it worse? Does the patient feel better or worse? If they're worse, has the infection progressed? Is the patient immunocompromised? Are there some non-infectious processes going on? And are there adverse drug reactions such as drug fever that are going on that are making the patient feel worse despite the infection getting better? You want to evaluate the patient using objective measures. So looking at laboratory values. So is their white blood cell count resolving? If they are thought to have an intra-abdominal process or an obstruction, is their T-bili getting better? Temperature. Is their fever curve down? Are they afebrile? Hemodynamic status, so is their blood pressure stable? Are they not tachycardic? Do they have normal heart rate? Respiratory support requirements, are they on the vent? Are they not on the vent? Do they require BiPAP but now they're just on nasal cannula oxygen? And then also organ function. So typically, when somebody has a sepsis syndrome, boy oh boy, we see a lot of changes, especially in their renal function. Organ function declines very rapidly and significantly. When we start to see that organ function return in a patient who's got suspected sepsis syndrome, we tend to start to think that the patient's getting better. Okay, so now we're going to go over a few guidelines with a couple of case discussions. So community-acquired pneumonia. Basically, you risk stratify these folks based on if they go to the ICU or if they don't go to the ICU. So if they're a non-ICU patient, they have some of the same, but some distinctly different bacterial pathogens that you need to cover for. So for the non-ICU patient, CAP, you're really thinking a lot of strep pneumoniae. That's typically your number one. You can still have Mycoplasma pneumoniae, Chlamydia pneumoniae, Haemophilus influenzae, some Legionella species, especially if there are inhaled water droplets, and then aspiration pneumonia. So aspiration you think of anytime you have somebody who abuses alcohol or drugs. So empiric antibiotic therapy would be a respiratory fluoroquinolone or a beta-lactam plus a macrolide. So the beta-lactam plus a macrolide, we have just recently changed our CAP algorithm to first-line therapy be ceftriaxone plus azithromycin. We're only using fluoroquinolones in patients who have severe penicillin allergy. There have been a lot of FDA warnings and alerts out there regarding fluoroquinolones and some of their negative effects, including QT prolongation and including resulting in altered mental status in elderly patients. So we're shying away from them a little bit more. If your patient has non-ICU pneumonia that you think is due to aspiration, it's not included in the CAP recommendations. They're going to require antibiotics that cover gram-negative and anaerobic organisms, since it's basically you've inhaled gastric contents. ICU patients, you're still thinking strep pneumoniae, but you can also think Staph aureus, Legionella, some gram-negative rods, depending on what your risk factors are, and Haemophilus influenzae. So if you have ICU, you can patient, you're going to think about a beta-lactam and either azithromycin or a respiratory fluoroquinolone. A lot of folks will use, for this beta-lactam, they'll use cefepime. Some will use ceftriaxone plus azithromycin or the respiratory fluoroquinolone, so either Levaquin or moxifloxacin. If there's a penicillin allergy, you want to give a respiratory fluoroquinolone plus aztreonam. There are some patients who are at risk for Pseudomonas species, particularly COPD patients tend to have a higher incidence of Pseudomonas isolates. And so empiric therapy for them, you're going to use an anti-pneumococcal beta-lactam plus Cipro or Levaquin, or the above beta-lactam plus azithromycin, or the above beta-lactam plus an aminoglycoside plus an anti-pneumococcal fluoroquinolone. So when we talk about that, we talk about using Zosyn, cefepime, imipenem, or meropenem, and that would be used plus Cipro or Levaquin, or plus azithromycin, or plus an aminoglycoside and an anti-pneumococcal fluoroquinolone, and that would be like Levaquin or moxifloxacin. If the patient has a penicillin allergy, you're going to want to replace the beta-lactam with aztreonam. There's also community-acquired MRSA patients. So those patients, maybe they've had previous cultures that are positive. Maybe they are colonized with MRSA in the nares, and it's very easy for it to transport then over to the lungs. And so if you've got a patient who's got community-acquired MRSA, or you suspect of that, you're going to want to add vancomycin or linezolid to the appropriate regimen. The guidelines give further guidance on preferred antibiotics for de-escalation based on the organism that you believe to be isolated, or the organism that you believe is most likely the causative agent. For Streptococcus pneumoniae, the minimum inhibitory concentration of less than 2, you can use penicillins for that. If you have penicillin allergy, you can use some of the different cephalosporins. You can use a macrolide, such as azithromycin. You can use Clinda, Doxy, or a respiratory fluoroquinolone, such as Levaquin or moxifloxacin. For strep pneumo, with a higher minimum inhibitory concentration, so we worry a little bit more about resistance with this, you're going to base it on the susceptibility pattern, but usually you want to use cefotaxime, ceftriaxone, or a respiratory fluoroquinolone. If you do have allergies, you're going to want to go to vancomycin, linezolid, or high-dose amoxicillin. For Haemophilus influenzae, non-beta-lactamase producing, you're going to go ahead and stick with the penicillins here. If you have an allergy, you're going to want to go with a respiratory fluoroquinolone, doxycycline, azithromycin, or clarithromycin. If you have to pick, though, between azithromycin and clarithromycin is the better agent. It does have better activity. And then Haemophilus influenzae that does produce a beta-lactamase, you're going to want to use a second or third generation cephalosporin or augmentin, because it does have that beta-lactamase inhibitor, clavulanate. And the alternative antibiotic for de-escalation, if you've got allergies, you're going to want to use the same thing as for the non-beta-lactamase producing. So that would be the respiratory fluoroquinolone, doxy, azithromycin, or clarithromycin. So when we think about community-acquired pneumonia, some of the other organisms are Mycoplasma pneumoniae or Chlamydia pneumoniae. Preferred antibiotics for de-escalation would be macrolides or a tetracycline such as doxycycline or monocycline. Alternative antibiotic, if you've got an allergy, would be a respiratory fluoroquinolone. For Legionella species, you can use the respiratory fluoroquinolone or azithromycin. Alternative would be doxycycline. For Pseudomonas aeruginosa, you're going to use an anti-pseudomonal beta-lactam plus Cipro or Levaquin or an aminoglycoside. And then for Pseudomonas alternative, it would be an aminoglycoside plus Cipro or Levaquin. For MSSA, so methicillin-sensitive Staph aureus, you're going to use an anti-staphylococcal penicillin, vancomycin, or linezolid. An alternative antibiotic would be Ancef or clindamycin. MRSA, you got to think about vancomycin or linezolid. Linezolid has great lung penetration but is bacteriostatic. Or the alternative antibiotic would be Bactrim. So here's a community-acquired pneumonia case. So we've got KM. It's a 63-year-old patient that presents with a history of coughing and wheezing for the past 5 days. Originally, she thought she was getting a cold. However, her symptoms have been getting worse, and she states that she's never felt this wiped out from a cold. She's become more short of breath over the past 24 hours. Her vitals are as follows. She has blood pressure of 110/80, heart rate of 96, respiratory rate of 26, temperature of 101.6 Fahrenheit, 94% oxygen saturation. She's 65 inches tall and weighs 70 kilos. KM denies a history of lung disease, asthma, or COPD and lives with her husband in their home in Homewood. She will be admitted to the hospital with a diagnosis of community-acquired pneumonia. She has an allergy to sulfa, which gives her hives, and reports stomach upset with penicillins. So which is the most appropriate empiric antimicrobial therapy for KM? Vancomycin plus Zosyn, Levaquin plus cefepime plus tobramycin, azithromycin, or azithromycin plus ceftriaxone? Okay, now that you've got your answer, let's step through the case. So she does not have any risk factors for more resistant organisms. She lives at home. She doesn't have any lung disease, no history of COPD or asthma. She's generally in good health. She is febrile, but we look at what the likely organisms are for her. So when we think about the likely organisms for her, we think Streptococcus pneumoniae, Mycoplasma pneumoniae, maybe Legionella, but probably not. So we think about the first line therapy for community-acquired pneumonia, which is azithromycin plus ceftriaxone. Skin and soft tissue infections are very common, especially during the summer months. They get classified in a number of different ways, so non-purulent versus purulent. Non-purulent infections include necrotizing infections, cellulitis. Purulent infections are some of those with pus, furuncles, carbuncles, or abscesses. When you have non-purulent infections, therapy is guided based on how severe it's deemed to be. Culture and sensitivity, if it's a necrotizing infection, that's a possibility, but for cellulitis, you can't really culture something that doesn't have a head or doesn't come to the surface. When it's purulent, you've got pus, you can do an incision and drainage, which is typical therapy regardless as to what the severity is. And then you do your empiric therapy based on how severe the infection is. You'll notice here that telavancin is still in the guidelines here, which I think is probably going to disappear once these get updated. So, if you've got a methicillin-sensitive Staph aureus skin and soft tissue infection, nafcillin is the parenteral agent of choice, followed by Ancef, clindamycin. You do have a risk of higher risk, according to the literature, of C. diff if you use clindamycin. Dicloxacillin, which is difficult to use. It's the oral agent of choice in adults, but I believe it's 4 times a day dosing, which makes it tough. Also with cephalexin, that can make compliance tough as well. Doxycycline and minocycline are decent options, although they are bacteriostatic, and minocycline does have inducible resistance. So if you are going to pick minocycline versus doxy, doxy's the better choice. And then there's also Bactrim, which is a good choice, but if you've got somebody who's got allergies or has super sun sensitivity, you have to be cautious of that. Methicillin-resistant Staph aureus skin and soft tissue infection, your treatments of choice are going to be vancomycin, linezolid, clindamycin, although you do have to watch out because there is inducible resistance, and more MRSA strains are becoming resistant to clindamycin. Daptomycin for severe infections that are resistant to vancomycin. Ceftaroline, again, specific indicator antibiotic, should only really be reserved for patients who are treatment resistant. Doxycycline or minocycline, sometimes those get de-escalated as far as an oral option when somebody's going to go home after getting IV therapy, and then Bactrim as well. If it's non-purulent, so if there's no goop and you think it's a strep species, your options are penicillins, Clinda, nafcillin, Ancef, penicillin VK, and cephalexin. And here's our case. We got JK, 55-year-old man. He presents at a follow-up appointment with an infectious disease physician. He continues to have issues with a subcutaneous abscess on his leg. He reports that he is still in pain. His vital signs include blood pressure of 146/95, heart rate of 92, temp of 99.5 Fahrenheit, and white blood cell count of 19,000. His wound culture is positive for Staph aureus, and the susceptibilities for the isolate are as follows. So it's intermediate sensitivity to clindamycin, it's sensitive to doxy, it's resistant to erythromycin, it's sensitive to levaquin and moxifloxacin, it's sensitive to linezolid, methicillin it's resistant, penicillin it's resistant, Bactrim it's sensitive, rifampin it's sensitive, and vancomycin it's sensitive. So which one of the following is the best for the treatment of JK's Staph aureus infection? Rifampin 300 mg PO BID, moxifloxacin 400 mg PO daily plus rifampin 300 mg PO BID, linezolid 600 mg PO BID, and linezolid 600 mg PO BID plus moxifloxacin 400 mg PO daily. So take a step back and think about that. So rifampin is an antibiotic that is often used as an additive agent to other therapy when you think that the response is incomplete or delayed, or when you think that you have a MRSA infection that requires boosting of activity. It used to be very popular to add rifampin to vancomycin to try to boost the activity of vancomycin. But rifampin as a single agent, especially at a dose of 300 mg, is simply not appropriate. Moxifloxacin 400 mg plus rifampin. So moxifloxacin, if you looked at the culture and sensitivity data, you see that it's sensitive to both moxifloxacin and levaquin. Unfortunately, this is the difference between in vitro sensitivity and in vivo sensitivity. So sometimes things work best in the test tube, but when you actually put them to use in real life, they don't work well at all. So while the bug, when it was grown in the lab, might be sensitive to levaquin or moxifloxacin, it is really unlikely to be able to clear the infection, and thus fluoroquinolines are not used for skin and soft tissue infections that are thought to be due to resistant Staph aureus. Linezolid plus moxifloxacin would be dual therapy where kind of would have overkill. What exactly are you using the moxifloxacin for? Linezolid would provide sufficient coverage. In this case, there are other agents that we could use, but if we're looking at the best choice out of the four choices, linezolid 600 mg PO BID is going to be our best choice. But are there other choices? What else do you think we could use? Think about it. So I'm going to be sending out the competency questions. Please complete the questions associated with the presentations and submit them to me. The competency assessment will contain questions that will require research outside this presentation. So similar to situations you may encounter when you're staffing and you need to review patients' current antimicrobial therapy for appropriateness. If you have any questions about the videos or about the assessment, please let me know. The assessment will likely be due in mid-September, so more to come.